Hi, everyone, and welcome to the skills course entitled QTC Prolongation and Psychiatric Medications, an in-depth guide for the CL Psychiatrist. I'm Scott Beach, and I'll be one of the presenters today, and I'm joined by Christopher Solano and Margot Funk. We're hoping to give a comprehensive overview of issues related to QT prolongation and psychiatric medications. And a lot of the material that we're going to present today comes from a project that we had the privilege of working together on along with many other colleagues, and that was the APA resource document on QT prolongation and psychotropic medications that was released in June of 2018. Margot Funk was the lead on that, and Richard Kovacs, who's a cardiologist, was the senior author, and together we put together a set of recommendations for psychiatrists in terms of how to think about issues of QTC prolongation with regards to psychiatric medications. As I said, my name is Scott Beach, so I'm just going to take a few minutes to introduce the speakers. I'm then going to give an overview of today's agenda and what we hope to accomplish, and then I'm going to kick us off with the first couple of talks, and I'll be followed by Chris and then Margot. So I'm the program director for the MGH McLean Adult Psychiatry Residency Program, also an assistant professor of psychiatry at Harvard Medical School, and I work on the consult service and in the acute psychiatric services at Mass General. My interests, in addition to QT prolongation, are catatonia and deception syndromes. Chris Solano is the Associate Director for the Cardiac Psychiatry Research Program at Mass General, as well as an Assistant Professor of Psychiatry at Harvard Medical School. And Chris is really interested broadly in issues of cardiac psychiatry, collaborative care, as well as positive psychiatry, positive psychology, and health behavior promotion. And Dr. Margot Funk is the program director at Harvard South Shore for their residency there. She's also a consultation-liaison psychiatrist there. As I mentioned, she was the chair of the APA work group on this issue. She's also a member of the APA Council on Consultation-Liaison Psychiatry, and her interests, in addition to issues of QT prolongation and cardiac psychiatry, include medical education and the advancement of women in healthcare leadership. So our objectives for today's course are to allow you by the end of these talks to confidently measure the QT interval, to choose the most appropriate correction formula, and to calculate the QTC. We'll also help you to think through and list medications and common drug interactions that confer a high risk for torsade de poids. We hope that you'll be able to correlate components of the 12-lead EKG with cardiac electrophysiologic mechanisms. Describe high-yield strategies for various practice settings and populations, including the intensive care unit, substance use disorders, and resource-poor clinics. And finally, we hope that you'll be able to describe an approach to comprehensive risk-benefit analysis, including risk mitigation strategies, in patients who require control of high-risk psychopathology who also may be at risk for torsade de poids. Today's agenda, we're going to start with an overview of torsade and QT prolongation. Then we're going to jump into some of the specific psychopharmacology with a focus on antidepressants and antipsychotics. We're then going to review the basics of cardiac electrophysiology and EKG interpretation. And then we'll have some interactive EKG practice cases as well as finishing with an approach to risk stratification and mitigation. In terms of disclosures, I don't have anything to disclose with regards to this talk. So I'm going to kick us off with a discussion of torsade and QT prolongation in general. Torsade is the thing that we all worry about, right? When we're talking about issues of QTC prolongation, what we're really talking about is risk for torsade, and that's kind of the dread outcome here. So what is torsade? Well, it's a malignant polymorphic ventricular tachycardia. It often presents with lightheadedness or syncope, but it can present with seizures or even sudden cardiac death. So there may be no sign of torsade before sudden cardiac death, and that's one of the reasons why people consider it a very dire consequence of QT prolongation. It's essentially a ventricular tachycardia that's associated with a long QT. And it's called torsade. Torsade de poids in French means twisting of points, and it gets that name from the rhythm strip that it shows. So you can see here it's a polymorphic ventricular tachycardia that changes in amplitude but appears to twist around a center point. There are estimated to be 12,000 cases per year in the US, though that may be an underestimate given that many of the cases of sudden cardiac death may or may not be related to Torsade. The rates are very tricky to pin down for that reason, but it's estimated that it may be 1 in 12,000 to 1 in 120,000 patients. And it has a very high morbidity and mortality, up to a third of patients. Most cases occur in the setting of long QT syndrome, either congenital long QT syndrome, which is a group of congenital genetic syndromes that have a characteristic QT morphology, or in the setting of acquired long QT syndrome, which means that QT prolongation occurs under certain clinical conditions, and that can be due to medications, it can be due to other risk factors as well that then lead to Torsade. It's important to recognize that the relationship between QTc prolongation and Torsade is imperfect. So QT prolongation is only a marker of risk for Torsade. There's no number that indicates that Torsade is imminent or definite. In the absence of other risk factors, drug-induced QT prolongation rarely leads to Torsade. So the vast majority of patients who have a Torsade that's related to a medication have multiple other risk factors for Torsade. In a case review, a case series, 229 cases of drug-associated Torsade, 96% of those patients had at least one other risk factor besides the medication. The mechanism of drug-induced Torsade is related to direct blockade of what's known as the IKR channel, or the delayed potassium rectifier current. This causes a disruption of potassium efflux, which delays repolarization of the ventricle. This leads to a widening and distorted T wave, and it manifests as prolongation of the QT interval on a 12-lead EKG. There are many risk factors for Torsade, and it's important to go through these and understand which are modifiable and which are non-modifiable. So some of the major non-modifiable risk factors. So female sex conveys an increased risk for Torsade. This is thought to occur between puberty and menopause. It's thought to potentially be hormonally mediated. It is not true in children, and it doesn't appear to be true in older adults. But between puberty and menopause, female sex does convey an increased risk. Advanced age is also a conveyor of risk. So a good rule of thumb is the older somebody is, the more likely they are to have QT prolongation and the greater their risk for Torsade. Another good rule of thumb is the sicker somebody is, the more likely they are to have QT prolongation and the greater the risk for Torsade. As we mentioned earlier, congenital long QT syndrome, as well as other genetic syndromes that affect metabolism, also may be non-modifiable risk factors. Personal history of drug-induced QT prolongation or history of any cardiac disease is also a risk factor for Torsade, as is a family history of sudden cardiac death. In terms of modifiable risk factors, QT prolonging drugs are certainly risk factors, and the use of more than one drug that can prolong the QT will increase the risk. It's also important to keep in mind that pharmacokinetic drug-drug interactions may increase the risk by elevating the levels of certain QT prolonging drugs. As I mentioned, medical illness, and particularly severe acute illness, is a risk factor, as is starvation, hepatic impairment, and renal impairment. Perhaps the most important risk factor, which many people are unaware of, is bradycardia. So when somebody has a QT that's prolonged, if they are bradycardic, they are at significantly greater risk for Torsade than is somebody who is tachycardic. And this is relevant to our field because many of the patients that we're treating with psychiatric medications in the hospital, for whom we have the most concern about Torsade, are often tachycardic because of their agitation or because of other factors, and that tachycardia may actually be somewhat protective. And finally, there are electrolyte abnormalities that are associated with an increased risk for Torsade. These include hypokalemia, hypomagnesemia, or hypocalcemia, and so it's very important that we focus on repletion of electrolytes as one of our key recommendations. In terms of the EKG, the QT interval begins at the beginning of the QRS wave and ends at the end of the T wave. So that's the interval that we're talking about, and that captures ventricular depolarization as well as ventricular repolarization. It's also important to keep in mind that the QT interval is heart rate dependent. So the QT interval actually shortens at higher heart rates. And for that reason, it's important that we correct the QT for heart rate or derive the QTC. There are many different formulas to correct the heart rate, and it turns out that the formula we choose may have a big impact on the QTC. The most commonly used formula is known as the Bizet's formula, and it's a square root formula that's shown here. The Bizet's formula is the default formula on almost every EKG machine in the country. So if you're reading a QTC directly off the EKG machine, chances are it's been calculated using the Bizet formula. That becomes really important because the Bizet formula is great at correcting for heart rate when the heart rate approximates 60 beats per minute. But the farther away from 60 the heart rate gets, the worse a formula is, Bizet's is in terms of correcting. So for patients who are very tachycardic or for patients who are bradycardic, Bizet's is actually not a very good formula for correcting the QT interval. It tends to overcorrect at faster heart rates, and it tends to undercorrect at slower heart rates. Fridericia's formula is a cubed root formula, and that actually performs quite a bit better than Bizet's formula, and so is a nice alternative. But the American Heart Association for years now has actually recommended the use of a linear correction formula to correct for heart rate. There are several available. Framingham is perhaps the most widely known. One of the ones that we're a big fan of at Mass General is the Hodges formula, which is shown here. We really like it because it's the only correction formula that can be calculated directly using the heart rate rather than the RR interval. And so it's a great kind of quick and dirty linear correction formula that we can use to get a better approximation of the QTC than we will get if we just use the Bizet formula that the EKG machine spits out. There's also something that's been developed known as the QT nomogram. That's shown here. It essentially plots a QT interval over heart rate, and patients who are above the QT nomogram have an increased risk for torsade. Patients who are below the QT nomogram have a decreased risk. It's similar to the Tylenol nomogram, but it doesn't require you to derive any specific QTC. You're just plotting the QT interval as compared to the heart rate. As I said before, Bizet tends to overcorrect at higher heart rates, and it actually has the widest correction range in terms of the formulas, and I'm going to show you what I mean by that in a minute. The other formulas tend to group together when plotted, whereas the Bizet formula deviates significantly as the heart rate increases. And we can see that here. So the Bizet formula is shown in red. You can see that it's shifted to the right more than the other formulas, which suggests that it tends to overcorrect more than the other formulas. And it also has a much wider area under the curve, which suggests a wide correction range, whereas the others tend to group together in a narrower range. This is also demonstrated here when the correction formulas are plotted together. And you can see as the heart rate increases, Bizet's goes kind of really off the graph in terms of overcorrecting the QT interval, whereas the other correction formulas largely align. So we would really discourage people from using Bizet formula and encourage people to use a linear correction formula. And the very first thing I do whenever I get a consult related to QT prolongation is I ask the primary team to let me know what the heart rate is, what the QT is that the EKG machine tells them, and then what the QTC is that the EKG machine tells them. And I'll usually correct myself using Hodges. We're going to show you a little bit later how to calculate, how to hand measure the QT and also how to calculate, but that's a good rule of thumb to start with, is you want to try to get an accurate reading, and a linear correction formula is often a great way to do that. What is normal when it comes to QTC? Well, that's been debated quite a bit, and the ranges have actually evolved over the years. The current definitions are that for adult men, prolonged QT is anything over 450 milliseconds, and for adult women, a prolonged QTC is anything over 470 milliseconds. Again, though the ranges have shifted a little bit over time. The big take home here is that women tend to have longer QTs, and as I mentioned earlier, they may therefore be at increased risk for torsade. And as I mentioned before, the relationship between QT and torsade is also imperfect. There is a formula to attempt to sort of calculate the risk, and that says that the risk of ventricular arrhythmias increases by 1.052 raised to the x power, where x is every 10 milliseconds above a QTC of 400 milliseconds. So if you do the math, that would imply that somebody with a QTC of 450 milliseconds has a 1.29-fold increased risk of ventricular arrhythmia. And if you carry that out, it also implies that somebody with a QTC of, say, 550 milliseconds has something like a 2.76-fold increase. Now, if we think about the base rate of torsade, remember that it's quite a rare event, 1 in 12,000 to 1 in 120,000. And that actually suggests that even for QTCs that we would get really alarmed by, 550, 600 milliseconds, the absolute risk of torsade remains quite low. We're going to shift now, and we're going to talk about psychopharmacology and some specific medications with regard to the propensity to prolong the QT interval. I'm going to start by talking about antidepressants, and I'm then going to hand it over to Chris Solano, who's going to continue by talking about antipsychotics. I want to outline first, whenever we talk about medications, there are a lot of limitations in terms of the available data. There are limitations of study populations, which often include healthy adults, and so they may not be the real populations that we're used to seeing on the consult service. The method of QTC measurement is also a major imperfection. As I mentioned, Bazette formula is the worst formula, and yet it's the formula used in almost all studies and all literature, and that makes it really challenging. The timing of the measurement is also a potential limitation. Oftentimes measurements are not derived at peak dose, or not derived at times when it sort of best fits the needs of the research. And then other medications may be big confounders. And if you read case reports or case series literature, you'll see that a lot of patients are on other medications that may also prolong the QT interval. The reported QTC also is not always clear whether that's a mean or whether it represents a clinically meaningful change, meaning if somebody has a QTC that prolongs by 10 milliseconds, does that actually impact anything from a clinical standpoint? Finally, I think it's important to mention Credible Meds. So Credible Meds is a website that purports to sort medications into different risk stratifications related to torsade. In some ways, it's a very useful website. It's good to get a sense of whether a medication might carry any risk of torsade. But the challenge with Credible Meds is that it tends to lump medications together, and often medications that seem very disparate in terms of their actual risk are lumped together in a similar category. I would say, as a rule, Credible Meds tends to overestimate the risk of most medications. So to start with antidepressants, really the story of antidepressants and QTC prolongation is a story of the citalopram controversy. And this really started in 2011. So actually, just as I finished up fellowship, we got this report of citalopram being associated with QTC prolongation. This had a major impact at Mass General. So because of STAR-D and other trials, citalopram was really the #1 antidepressant that was used in our institution. And this FDA warning is actually the only time I can ever remember the chief of our department sending out an email to flag a clinical warning and to encourage people to consider alternative agents. So it had a significant impact on practice. So as I mentioned, started in August of 2011 with the FDA issuing a drug safety communication. And that first communication said that citalopram should not be prescribed at doses greater than 40 milligrams, and that it should not be used at doses greater than 20 milligrams in patients with liver dysfunction or those over the age of 60. About 6 months later, the FDA revised its recommendation. It downgraded the language, and it said that citalopram is not recommended at doses greater than 40 milligrams, and that it should be discontinued in anyone with a QTc of greater than 500 milliseconds. So this was a pretty big deal. These recommendations were actually based on a single study, and that is a type of study known as a thorough QT study, which is sort of the gold standard kind of study. And that study showed an increase in the QTc of 8.5 milliseconds at a dose of 20 milligrams of citalopram, and an increase of 18.5 milliseconds at a dose of 60 milligrams of citalopram. The study didn't actually measure the increase in the QTc at 40 milligrams of citalopram. So no patient in the study ever received 40 milligrams of citalopram. That increase was extrapolated from the data at 20 milligrams and at 60 milligrams. So that's an interesting note on the study. The other interesting note on the study is that the 18.5 millisecond increase at 60 milligrams didn't meet the threshold that was typically considered the threshold needed for a drug to be declared as dangerous with regards to QTc prolongation. That always hovered around 20 milliseconds. And the FDA actually based its recommendation not just on the absolute increase in the QTc, but also on an assertion that 60 milligrams of citalopram was no more efficacious than 40 milligrams of citalopram. So essentially, the FDA suggested that the increase to 60 milligrams could not be justified because there wasn't evidence to suggest that 60 milligrams was any better than 40 milligrams, and therefore it wasn't worth the potential increased risk with regards to QT prolongation. A very similar thorough QT study was conducted with escitalopram, and that showed that escitalopram does prolong the QTc, though to a smaller extent. So 4.5 milliseconds at 10 milligrams and 10.7 milliseconds at 30 milligrams. The FDA did not issue any warnings related to that change, though the MHRA did actually issue a warning for citalopram as well. So one of the big questions that's come out of these warnings is citalopram unique in some ways? Is it different from other SSRIs? And there's been a lot of inquiry into this since 2011, a lot of different studies. And I will say most of those studies have sort of verified the FDA's finding. They've suggested that citalopram does cause QT prolongation on the order of about 10 to 20 milliseconds, that it does appear to be dose dependent, and that it does separate out from other SSRIs. So our institution conducted a cross-sectional study of EKGs in 38,000 patients and found that citalopram was associated with dose-dependent QT prolongation of similar magnitude to the FDA study. Our group conducted a systematic review and meta-analysis of 16 prospective studies involving over 4,000 patients, and we found that citalopram and actually escitalopram had statistically greater QTc prolongation than placebo, and that citalopram separated out from all other agents except for escitalopram. Other studies have been done showing similar findings. So a mean increase of 18 milliseconds after 3 weeks of a dose of 30 milligrams daily. In a sub-analysis of the Rotterdam study, citalopram caused an average increase of 13 milliseconds. And there's been some other retrospective studies that have shown that as well, though a small one suggested that there may be no association with increased QT prolongation. So I would say the evidence is pretty clear that citalopram does cause some QT prolongation. So the next question is, what about citalopram and Torsade? There, the evidence becomes a lot less clear. There's been a couple of large studies, a VA cohort study in close to 1 million patients, found that citalopram at higher doses was actually associated with a lower risk of ventricular arrhythmia as well as all-cause mortality. And then a Tennessee Medicaid cohort study found that high-dose citalopram does not differ from other agents in terms of sudden cardiac death or mortality. So one way to put together all of this data is to think that perhaps citalopram does increase the QT interval, but that the actual risk of torsade associated with that increase is not clinically significant. So maybe there is an increase of 10 to 20 milliseconds with citalopram, but by and large, that 10 to 20 milliseconds is unlikely to be clinically meaningful. It's also really important to emphasize that prescribing lower doses of citalopram, which happened in response to the FDA warning, is actually quite risky. So studies have shown that 50 to 65% of patients who were on doses of 40 milligrams or more at the time of the warning were reduced to doses of 40 milligrams or less within 2 years. At the same time, there were actually increased prescriptions for medications that interacted with citalopram in a way to convey an increased risk for QTc prolongation. And EKG monitoring did not change over time, so people were not more cautious with regards to monitoring. Importantly, older adults were less likely to have their doses reduced to comply with the guidelines that recommended less than 20 milligrams, with 30% remaining on the higher dose after 1 year. As a result of this reflexive lowering, patients actually had increased rates of psychiatric hospitalization and increased rates of all-cause mortality. They did not have any reduction in hospitalizations for arrhythmia or all-cause death, suggesting that there was no benefit from a cardiac standpoint, but there were real risks from a psychiatric standpoint. Those patients were more likely to be prescribed sedatives or anxiolytics, and they had higher healthcare utilization. So overall, their disease, psychiatric disease, got worse. They were prescribed more meds, sometimes other medications that might increase their risk for QTc prolongation or torsade. They weren't monitored any more closely, and they didn't have any reduction in cardiac outcomes. Well, what about escitalopram? As I mentioned, there's a similar pattern of dose-related QT lengthening, but no FDA warning followed. Escitalopram does separate out from other SSRIs in some studies, but it was not associated with greater mortality in studies like the Tennessee Medicaid cohort. In addition, there's a large meta-analysis of about 2,400 patients that shows a mean increase with escitalopram of only 3.5 milliseconds, and only one patient in that whole sample who had a clinically significant QT prolongation. So our overall take-home message about escitalopram is that it may carry some risk of mild prolongation, but it's very unlikely to be clinically significant, and we would not alter our prescribing practices out of concern for QTc prolongation. Thinking about other antidepressants, it's important to keep in mind that SSRIs as a class are largely considered very, very safe in cardiac patients. They are, in fact, the agents most studied in cardiac populations. Even prior to 2011, case reports existed for all SSRIs with regards to QTc prolongation or torsade, except for paroxetine. So they have all been linked, but the risk remains very low. And so we get questions all the time about a cardiologist who's concerned about prescribing sertraline in a patient because of a theoretical risk for QTc prolongation. I have zero concerns about that. Sertraline is extremely well studied in cardiac populations and appears to be a very, very safe medication. Tricyclic antidepressants, on the other hand, it's important to keep in mind that those are sodium channel blockers, so they cause QRS widening. They really pose a danger at therapeutic doses only in patients with pre-existing bundle branch disease or ischemic heart disease. The real danger with TCAs comes in the setting of overdose, where they may harm even patients who don't have underlying heart disease. There's some evidence to suggest that perhaps amitriptyline and mepratoline among the tricyclics are the ones most commonly implicated in torsade, though it is hard to risk stratify among the tricyclics. With regards to other newer antidepressants, I would say of non-citalopram antidepressants, venlafaxine is the agent that probably has the second most evidence for mild to moderate QT prolongation. Most of those cases have occurred in the setting of overdose and other risk factors to note. So in general, I don't worry about venlafaxine. If somebody has significant other risk factors for QT prolongation or torsade, I might not prescribe venlafaxine as my first option, but it's not one that I really worry a significant amount about. Bupropion is generally thought to be safe in this regard. There are a couple of reports of QTc prolongation occurring in the setting of overdose, but those are likely significantly confounded by tachycardia and then the use of Bazette formula to correct. Mirtazapine is one that comes up from time to time. There are a couple of conflicting studies. There's one study showing that even in overdose, 0 patients had a clinically significant QTc prolongation. There is another study that linked mirtazapine with increased sudden cardiac death, but the authors of that study hesitated to make a causal association. And another study actually showed a significant lower risk of cardiac events. So I get asked about mirtazapine more than a lot of antidepressants by cardiologists, but I generally say I think it's safe. The evidence for it being dangerous is not really robust. Again, it's not one that I really worry about. I think about mirtazapine for other reasons, not being great for cardiac patients with regards to metabolic side effects, but from the standpoint of QTc prolongation, I tend to not worry about it so much. And then thinking about other agents like duloxetine, vilazodone, desvenlafaxine, vortioxetine, and some of the newer agents, I really don't worry about them. They have not been associated with clinically meaningful QT prolongation. So how do we think about all this data together, and how do we use antidepressants in patients who may be at risk? I would say the take home here is that the overall magnitude of QTc increase with SSRIs is very small. I don't think there's any indication for a baseline EKG with a garden variety antidepressant initiation. I would consider a baseline EKG for a patient who has significant risk factors being started on an SSRI or an antidepressant other than citalopram. So if somebody had 3 or 4 different risk factors for QTc prolongation and you were going to start them on an antidepressant, if it's feasible and reasonable and relatively easy to get an EKG, I would probably check a baseline just to make sure that there's no QTc prolongation at baseline. For patients who you're thinking about citalopram with, I would say it does appear to be the worst offender among the antidepressants, but actual QT prolongation remains minimal. Citalopram is honestly not my first choice for patients with pre-existing cardiac disease. There aren't many cases that would really justify picking that one as opposed to other SSRIs, just given the somewhat increased risk. I would say sertraline still remains first line by and large. And if I'm going to start citalopram, I probably would consider a baseline EKG, even if the person has no other risk factors. Again, if it's feasible. There are some guidelines in other countries. So the 2018 Dutch guidelines recommend EKG monitoring for patients with 2 or more risk factors being started on citalopram or escitalopram. So they're not super conservative, actually. If somebody has fewer than 2 risk factors and you're starting them on citalopram or escitalopram, they don't even recommend any baseline monitoring. For patients with a really significant QT risk, if I'm starting citalopram, in that case, I might consult cardiology. Or if I think I'm going to go above 40 milligrams of citalopram, I might consult cardiology. But one of the key take-home points here is that you should not reflexively reduce the dose of citalopram below 40 milligrams just because you see that somebody's on it and you worry theoretically about QT prolongation. There are cases where I think you could very easily justify having somebody on 60 milligrams for therapeutic reasons. Remember that part of the FDA's decision was based on sort of population level data, but I think we all know that there are individuals for whom 60 milligrams of citalopram may make a real difference in the course of their illness. I'm going to stop now, and I'm going to hand it over to Chris Solano to continue with the discussion of antipsychotics.
Thank you very much, Scott. So hi, everyone. My name is Christopher Solano. I'm an attending psychiatrist at Massachusetts General Hospital. And today I'm going to talk to you a little bit more about QT prolongation and psychiatric medications, hopefully giving you an in-depth view of how we think about measuring the QT interval and think about risk factors for QT prolongation. So my disclosures are that I have received funding from BioXcel Pharmaceuticals for research not related to this work. And I've also received honoraria from Synovion Pharmaceuticals for topics unrelated to this work as well. I should mention that Synovion Pharmaceuticals does make lurasidone, which is an antipsychotic medication that will come up in this presentation. So I'll bring this up again when that happens. So kind of continuing onwards from where Scott left off with the antidepressants, now I'm going to talk a little bit about antipsychotic medications. And in general, both typical and atypical antipsychotics have been associated with QT prolongation. When we think about typical antipsychotic medications, as a group, typical antipsychotics do appear to lead to pretty modest, like less than 5 milliseconds QT prolongation compared to placebo. That being said, this effect is likely primarily driven by phenothiazines because we know that low-potency phenothiazines in particular, such as thioridazine, chlorpromazine, and mesoridazine, are most associated with QT prolongation. Thioridazine in particular is the first antipsychotic medication that was linked to QT prolongation and probably is the worst offender in terms of QT prolongation of the different medications that we think about. These types of medications are also overrepresented in cases of sudden cardiac death, suggesting that it's not just QT prolongation that these things cause, but they can also cause ventricular arrhythmias, torsade de pointes, and other kinds of poor cardiac outcomes. In studies that have looked at antipsychotics in general, it does appear that there may be some kind of dose-dependent or dose-response relationship between antipsychotic dose and amount of QT prolongation, although this is a little bit mixed in terms of the evidence. When we think about typical antipsychotic medications that are not low potency, but we think of the higher potency medications like pimozide, fluphenazine, droperidol, and loxapine, they also have been associated with some QT prolongation. I know that recently there have been a few studies looking at intranasal loxapine, for example, and it does cause kind of mild QT prolongation, but nothing too clinically significant. It's usually on the order of kind of like 5 milliseconds or so. Now, one medication that frequently comes up in terms of QT prolongation is haloperidol. Now, haloperidol is a medication that has received a lot of attention, particularly intravenous formulation. I'm going to start talking a little bit about the oral formulation first. And so this meta-analysis that I bring up here was done by Hune and colleagues in 2019. And this was a systematic review and network meta-analysis looking at a variety of antipsychotic medications for the management of schizophrenia. So the individuals who were in this study or in these studies really were primarily healthy individuals for the most part. They weren't delirious, medically ill patients. And so it's likely that they probably had fewer QTC prolonging risk factors than some of the patients that we see on the consultation service. But regardless, this is what they were kind of looking at. And when they looked at haloperidol and compared them to other atypical antipsychotics and placebo, it looked like haloperidol caused about 2 milliseconds of QT prolongation on average and was not statistically significantly different than placebo. And this was kind of very similar to other antipsychotic medications that were in that study. So this suggests that haloperidol is kind of pretty run-of-the-mill compared to the other medications. When you look at other kinds of randomized controlled trials that look at haloperidol compared to other antipsychotic medications, most studies suggest that there's about 5 to 8 milliseconds of QT prolongation with haloperidol, especially the oral formulation. And this is less or similar to many of the atypical antipsychotic medications. That being said, there is still potentially some risk, particularly for ventricular arrhythmias, sudden cardiac death, or other kinds of poor outcomes. There have been a few studies that have found that haloperidol is kind of associated with significantly increased risk of sudden death or ventricular arrhythmia or other kinds of poor outcomes compared to other medications. That being said, all of the observational studies that have really looked at this tend to have different kinds of limitations. Some of them control for a limited number of covariates. Some of them may not control for medical severity or other medications, for example. And so it can be a little bit challenging to really kind of parse out, what medications are kind of highest risk. Now, intravenous haloperidol has been kind of associated with potentially greater risk of QT prolongation than PO haloperidol. Although, as with the PO haloperidol studies, there also are limitations related to kind of controlling for confounding variables and other things like that. So in 2007, the FDA did release a warning suggesting that there was an increased risk associated with intravenous haloperidol and recommending telemetry for patients who were on intravenous haloperidol. And there do appear to be some instances where intravenous haloperidol may contribute to poor outcomes and QT prolongation. So Meyer, Mazzetti, and colleagues in 2010 did a systematic review of case reports and found that there were a number of case reports that really looked and implicated haloperidol in QT prolongation and torsades de pointes. There was kind of good news and bad news related to this study. I think the bad news was that most of the cases, 77%, showed that haloperidol was associated with torsades de pointes. The kind of good news was that it did appear that many of these cases were associated with other risk factors. So it wasn't just haloperidol. These patients tended to be sick and they tended to have multiple other risk factors or were on other QT prolonging agents. And I think this is kind of this is really kind of the crux of the challenge with intravenous haloperidol. Because if you think about the people who are getting intravenous haloperidol, they do tend to be people who are much sicker, they have delirium, they may not be able to take things by mouth, and it's likely that they have other kinds of comorbidities that may also be contributing to QT prolongation. And it's really hard for studies to kind of control for that. So this slide really kind of gets at some of haloperidol's unclear risks. So Scott Beach, who kind of just spoke in the earlier part of this presentation, did a review of intravenous haloperidol and its relationship to QT prolongation and other kinds of poor outcomes. And in looking at 11 prospective studies, 10 of them involving over 1,500 patients didn't really find significant evidence of QT prolongation. Furthermore, there really wasn't clear evidence that intravenous haloperidol causes greater QT prolongation than other atypical agents or oral haloperidol. And just as an example, one study looked at in patients with schizophrenia. And though this study did find that intravenous haloperidol was associated with QT prolongation, while PO haloperidol and other agents were not, this study didn't control for other QTc risk factors, didn't control for medical comorbidity or other relevant variables, which really just gets at what I was saying before, that it can be really hard in these kinds of observational studies to control for everything. And so it's really hard to say whether or not intravenous haloperidol carries a higher risk than other agents. So Scott did kind of go ahead and make some recommendations for the use of intravenous haloperidol and recommendations for monitoring related to its use. And I think these are kind of useful to kind of think about. I think they are in line with other kinds of guidelines and how I would think about these kinds of situations. So certainly you want to minimize risk factors and ensure repletion of electrolytes. If you are going to use a correction formula, it's typically better to use a linear correction formula than the Bazette formula, for example, and to think about different kinds of cutoffs for whether or not someone has QT prolongation or not. If someone really is on very low dose haloperidol, so less than 5 milligrams a day, and has less than 2 other risk factors present, it may not be necessary to monitor the ECG because, as we would see with other atypical antipsychotics or other medications, if you're using a low-risk medication at a low dose and you don't have other risk factors, we typically won't monitor. If somebody does have 2 or more risk factors, or if you are kind of giving someone doses greater than 5 milligrams daily, it may be useful to check a baseline ECG when in a non-emergent situation, and then at least one follow-up ECG to see whether or not prolongation occurred. This is typically preferably 30 to 60 minutes following administration so that you can really see kind of at the peak of the intravenous haloperidol bolus what the kind of QT looks like. If someone is getting more than 25 milligrams a day, you might consider daily ECGs to kind of look at that. And if you are kind of looking at someone who has a QT interval that's above 500 milliseconds, or they're getting very high doses of intravenous haloperidol, like over 100 milligrams, you might consider continuous monitoring. I think when I think about this in general, I think about getting an ECG really when risk factors are changing. And so there are different kinds of situations where this may occur. So if somebody is pretty stable in an outpatient setting, you may not need to be checking it all that frequently unless you're changing the dose. But if someone is in the intensive care unit and is having kind of fluctuations in electrolytes and is having multiple other risk factors for QT prolongation, that's when you would really be thinking about daily monitoring or maybe even continuous monitoring. And if you kind of do have enough concern about QT prolongation to stop using intravenous haloperidol, it's oftentimes better to use a non-antipsychotic agent than to switch to another one, because the risks associated with those other ones may be similar in some ways to intravenous haloperidol. So those are the typical antipsychotics. Now I'm going to kind of move to the atypical antipsychotics. And when we think about atypical antipsychotics, most of them do cause QT prolongation. And so if we think back to this same kind of systematic review and network meta-analysis from Hune and colleagues, that was looking at schizophrenia, this kind of review looked at placebo-controlled or head-to-head trials, and really that enabled them to kind of look and compare all of the different antipsychotic medications with each other and with placebo. And if we think about those results and we think about the kind of different types of medications that were used, there are a few kind of standout ones worth mentioning. So ziprasidone in particular is probably the most likely antipsychotic medication or atypical antipsychotic medication to cause QT prolongation. And so if you are kind of using this is something to be aware of. So in 2002, the FDA did issue a warning for QT prolongation related to ziprasidone. They recommended avoiding its use in combination with other QT prolonging agents or in people with a history of a cardiac arrhythmia. And when you kind of look at studies that look at ziprasidone, the average QT prolongation tends to be between 10 and 21 milliseconds. And a substantial portion of people actually have a greater than 60 millisecond increase, which is definitely clinically significant and noticeable. In that Hune meta-analysis, ziprasidone did perform the worst. It was kind of, the confidence intervals overlapped with iloperidone, but still was kind of the highest. In terms of other ones, quetiapine has been called out before related to this. The FDA has given a warning for quetiapine, recommending to avoid its use with other QT prolonging agents, people with a history of arrhythmias, and people with other metabolic deficits. Most of this was really based on case reports, and this generally occurs mostly in overdose or in use with in combination with other agents. If you look at the studies that compare quetiapine to other kinds of medications, most studies really suggest that quetiapine causes somewhere on the range of like 3 to 6 milliseconds of QT prolongation, so not huge. But there are some reports that about 12% of people experience prolongation greater than 20 milliseconds, which is probably more clinically significant. And this kind of gets to a good point. I think that sometimes looking just at the mean QT prolongation is not really all that important. I mean, it may give you some indication of medications that are at higher risk or lower risk, but what we're really interested in and why we monitor is to look for those people who are not kind of your average person, but the people who are kind of at greater risk for QT prolongation and who may have 60 or 100 milliseconds of prolongation with one of these medications, where that really can make a big difference. Quetiapine also has been associated with an increased risk of out-of-hospital cardiac arrest, which is noticeable or notable. When we look at other medications, aripiprazole and lurasidone do appear to do best in the 2019 meta-analysis, causing basically zero QT prolongation. So if you are looking for a medication that for someone who is at kind of higher risk for QT prolongation, those may be good options. Again, lurasidone is made by Synovion Pharmaceuticals, so I'm just mentioning that now as well. Olanzapine, risperidone, quetiapine, and possibly clozapine are probably somewhere in the middle of the road. and then those other ones are higher risk. So when we kind of look in general at kind of QT prolongation risk with antipsychotics, the best ones appear to be aripiprazole and lurasidone. Middle of the road ones are kind of haloperidol, olanzapine, risperidone, and quetiapine. And then those with the greatest risk are probably ziprasidone, iloperidone, and thiazide. When we think about whether or not kind of polypharmacy may contribute to greater QT prolongation, it's really kind of unclear if giving people more medications or different medications is important. If it does cause something, it may be possibly mediated by the cumulative dose, because we have seen in some studies that there is a dose-response relationship between QT prolongation and dose. So how do we kind of go about using antipsychotic medications in outpatient settings? So first, if somebody is without risk factors, usually I wouldn't necessarily monitor the QTC unless we're kind of prescribing one of the higher risk medications that we mentioned. For people who are on who have multiple risk factors or are on other QT prolonging agents, or for people with no risk factors who are taking one of the higher risk agents, usually I would obtain an ECG at baseline and then again at steady state. And then again, if risk factors change. And then finally, for people who do have multiple risk factors who are also getting a high risk medication, that's when I would think about a cardiology consultation if needed. So moving on to mood stabilizers. This is kind of a little bit more straightforward than the antipsychotics. The good news is that anti-epileptic medications like valproic acid, carbamazepine, oxcarbazepine, those kinds of medications typically don't really precipitate prolongation of the QT interval. There's even kind of some mild indications that maybe valproate may be a little bit cardioprotective. And so that could be certainly an option for someone who has delirium and is agitated and isn't responding to antipsychotic medications, or is responding but is having a lot of QT prolongation. There's also no evidence to suggest QT prolongation with any of the other agents that I'm mentioning down here. Lithium, the data is a little bit less clear. There have been very few studies that have looked at the relationship between lithium and QT prolongation. And there is some evidence that especially kind of when there is lithium toxicity, or somebody is kind of has a level over 1.2 milliequivalents per liter, that there may be some evidence of QT prolongation. But really, when you're using lithium in its kind of therapeutic range, you're typically not really seeing clinically significant QT prolongation. Next is stimulants and stimulant-like medications. So when we think about stimulants and what they do, it does appear to be true that there is some risk of kind of increased arrhythmias, as well as possible QT prolongation with stimulants. Some of this may be due to kind of increasing catecholamines, increasing heart rate, increasing blood pressure. And so you're really kind of do want to kind of be aware of that for people who are receiving stimulants. That being said, when you look specifically at kind of methylphenidate or amphetamine drugs, it doesn't appear that there's any statistically or clinically significant changes to the QT interval, either with short-term treatment or with long-term treatment. Now, other medications that have been used for attention or ADHD, atomoxetine has been linked in a few case reports with QT prolongation. However, these people who kind of end up having QT prolongation typically have other kinds of contributing factors. And even those studies have found kind of that atomoxetine can affect cardiac potassium channels in vitro, which may be relevant in clinical situations, particularly in overdose. There has been kind of an analysis that looked at randomized double-blind trials that really didn't show any significantly increased risk in QT prolongation. This pooled analysis was done in children, adolescents, and adults. And when I was looking at those results, it actually did show that there may have been kind of some prolongation related when you measured QTC with the Bazette formula. but not when you measure it with other formulas, which to me would mean that it's probably being driven by heart rate, because we know that Bazette is probably the worst formula and tends to overestimate QTc at higher heart rates. So if you were taking a medication that kind of led to an increase in heart rate, like atomoxetine potentially could, then you would see that in the Bazette formula, but you wouldn't see that in some of the other formulas. Other medications for attention, modafinil, there's no real evidence that it causes clinically significant QT prolongation. And then clonidine and guanfacine also don't appear to cause statistically significant or clinically significant increases in QTc. So if we're monitoring patients who are prescribed stimulants, there really is no need to monitor in healthy patients, in cardiovascularly in patients who have no cardiovascular disease. I would use stimulants a little bit more in caution for people who have underlying heart disease, for people who have angina or severe coronary artery disease, for example, or people with arrhythmias or other kinds of cardiovascular medications. If you are giving a stimulant, usually we would recommend monitoring blood pressure and heart rate to kind of see the effects on those outcomes. And then in terms of other psychiatric medications, so there are a number of other commonly used psychiatric medications. Trazodone, we oftentimes use for insomnia, or sometimes for anxiety in elderly patients, or for kind of mild agitation in the setting of delirium. There have been some case reports showing that trazodone can cause transient QT prolongation, particularly with trazodone overdose. And there is a modest dose-dependent increase in QTc with trazodone, even at kind of clinical doses. I think that this probably is kind of clinically insignificant, that the increases are really small, but it is important to kind of note, because if you are kind of using an electronic health record, trazodone will typically kind of trigger that warning that it may cause QT prolongation. Benzodiazepines don't typically cause QT prolongation, and buspirone has been kind of associated in one study with increased QT prolongation, but I don't typically think of it as a big offender in terms of QT prolongation. Now, in terms of other medications, acetylcholinesterase inhibitors can cause QT prolongations. Donepezil in particular has been associated with case reports showing kind of QT interval prolongation, cardiac arrhythmias, and other kinds of poor cardiovascular outcomes. And so that's something to kind of be aware of. I think part of this, again, it can be really challenging to know what is related to kind of comorbid factors, because the people who are getting donepezil oftentimes are people who are older and have multiple other comorbidities. So I think that being said, even if you're using donepezil in a patient who is at higher risk, it may be worthwhile kind of monitoring QT and getting an ECG at the beginning and at steady state again. And then amantadine has been associated with torsades de pointes, especially in overdose and in co-ingestion, so it can cause QT prolongation. Now we'll talk briefly about opiates. So methadone is kind of classically known as a QT prolonging agent. It's in the highest risk category for torsades de pointes. And so there are a number of warnings related to this. The FDA specifically has a black box warning for methadone, talking about cases of QT interval prolongation and serious arrhythmia have been observed during treatment with methadone. And so it's something that you definitely should be aware of. There actually are some guidelines in terms of how you should monitor QT in this situation. And so the recommendations from SAMHSA really are that you get a baseline ECG, and again, within 30 days for patients with significant risk factors for QT prolongation. And then once someone is on methadone, it's oftentimes better to kind of get an ECG annually to kind of monitor the QT, or when the methadone dose exceeds 120 milligrams. If someone does have QT prolongation of greater than 500 milliseconds, sorry, that should be milliseconds, In that kind of instance, you would really want to think about other kinds of risk minimizing strategies, either reducing the dose if you need to, if the person can't tolerate a dose decrease due to risk of relapse, thinking about other contributing factors, transitioning to buprenorphine, which is much less associated with QT prolongation, or if kind of worse comes to worse, discontinuing methadone. Now, buprenorphine is a much safer medication from a cardiovascular standpoint. Buprenorphine has not really been shown to prolong the QT interval or to be associated with ventricular arrhythmias. It does kind of similarly block the delayed rectifier potassium channel, similar to methadone, but just at a much lower level. And then finally, we have this little section on non-psychotropic medications. And I think the reason why we have this kind of section is really because we tend to think a lot about psychiatric medications in terms of causing QT prolongation, and the medical teams who are seeing our patients oftentimes think of psychiatric medications, but psychiatric medications are really one of many risk factors for QT prolongation. If you look at the prevalence of other QT prolonging agents in people who are in various settings, it is very high. Over 100 non-psychiatric medications have been shown to prolong QT and or be associated with torsades de pointes. In the intensive care settings, 3 to 30% of patients are receiving QT prolonging agents, and 20% are co-administered 2 or more medications at once. In the emergency room, a lot of patients, the most commonly prescribed medications, oftentimes have effects on QT. And many patients in outpatient settings also have QT prolonging medications on their medication list. So this is something that is everywhere. It can kind of make us feel a little bit better that we're not the only ones doing this, but at the same time, we should be aware that many of the patients that we're seeing are going to be on QT prolonging agents, so we should be aware of that. So how do we kind of screen for this? I think that usually I would ask patients about over-the-counter medications, supplements, and other kinds of imported medications if it's not something that's in the electronic health record. I'll usually think about kind of common offenders right off the bat, so antiarrhythmic medications like amiodarone or sotalol, antibiotic medications, antivirals, antiemetics, and other kinds of similar types of medications. Sometimes if I really want to, I will kind of put everything in an interaction checker in kind of an app on my phone or online to kind of look at this. That's kind of good in terms of being thorough. It's a little bit clunky in terms of taking a lot of time and sometimes giving you, results that are not really specific enough to be clinically relevant. So just to kind of wrap up the psychopharmacology section of this, so medications are a risk factor for QT prolongation, but they're really only one of many. SSRIs, TCAs, antipsychotics, and various psychiatric medications can cause QT prolongation, and so it is important to be aware of which ones are most likely to cause it. If you're giving 2 or more QT prolongations, that's really of particular concern. And so definitely be aware of the non-psychiatric medications that can increase risk as well. I would try to avoid high-risk psychiatric medications when lower risk options are available. And really all of this is to kind of get you to really think about the risk-benefit analysis that you're performing whenever you're thinking about prescribing a medication to a patient. So next, I'm going to start and get into kind of cardiac electrophysiology and ECG interpretation. So I'm going to just spend a little bit of time with this before I pass it over to Margot for a little more discussion. So here we see kind of a typical ECG tracing showing the cardiac action potential. And just to kind of review what Scott had mentioned earlier, the QT interval really encompasses 2 different things. The QRS complex represents ventricular depolarization, and the JT interval, which includes the JT segment and the T wave, really reflects the cardiac repolarization. And it's this repolarization part that we're really most concerned about when we're thinking about QT prolongation, because during that prolonged repolarization phase, the cardiac myocyte can become susceptible to ectopic beats that can trigger some type of arrhythmia, such as torsade de pointes. So if we look at the physiology of the action potential, there's three main types of ions that are associated or involved in this whole process. There's the sodium channels, there's the calcium channels, and then there are potassium channels. And so at baseline, the cardiac myocyte membrane is kept at kind of a negative potential. And that's done primarily by potassium channels. And so when it's time to kind of trigger a beat of the heart, what happens is there's an influx of sodium ions, which you can see with the red line here, and which occurs down here with sodium flowing into the myocyte. This leads to rapid depolarization of the cardiac myocyte. What happens next is that calcium begins to come in and potassium begins to be pushed out. And so this leads to some type of plateau where there's kind of an even balance with calcium coming in and potassium being pushed out. And eventually what happens is the calcium channels tend to close and potassium takes over. And then what ends up happening is that potassium kind of re-establishes the kind of negative state across the membrane. Now, what happens when you're giving somebody a psychiatric medication or any other medication that kind of affects the delayed rectifier potassium channels is that these kinds of medications can end up blocking the potassium channels and they can cause repolarization to be delayed. So instead of having this kind of steep slope going up with the potassium current, you can see that this dotted line or this dashed line ends up kind of being slower, longer, and flatter than what you would typically see. And this ends up becoming important because this is, that period where the cardiac myocyte is at risk for these extra beats that can lead to arrhythmias. So what you can see here is just what we saw before in terms of the cardiac tracing. And what you can see is that if you look at this dashed line, this is what the T wave would look like if you were having a QT prolonging agent. And this is what we're worried about. So one of the things that we oftentimes get asked and think about is when should you order an ECG for a patient? So the short answer is that it's complicated. There's a lot of physiologic and pharmacologic factors that go into this. When I think about this, I really am thinking about when there's kind of some type of change in risk. So if there are changes to medications that affect the QT interval, changes in electrolytes, or changes in cardiovascular status, that's when I would typically be pushed to kind of order an ECG. You also might think about ordering an ECG if there's uncertainty about cardiac status, because if you think there may be a risk, that's when you would kind of want to get it. Of course, that being said, sometimes, when you're looking through people's charts, you'll see that there are ECGs in there and you can measure the QTC. Ideally, the measurement really should be no more than 1 month prior to the decision point. So sometimes I'll look at things and I'll see something from, 5 years ago. And while that may be great to kind of know that the QTC is not prolonged in that setting, things may be very different now. The patient's risk factors may be different. And so I would want to get an ECG closer to now. If you are using certain medications where guidelines are available, such as methadone, it's important to kind of look at those guidelines to make sure that you're following them as closely as you can. The next question comes up, who can interpret an ECG? This comes up particularly for people who are in the outpatient setting where there isn't a cardiologist who's reading every ECG that's ordered. And when we wrote the kind of resource document for the APA, people felt pretty strongly that even in situations where clinicians don't have access to a cardiology overread, we really feel like people from any medical specialty, including psychiatry, should feel comfortable with the measurement, calculation, and documentation of the QT interval. And so I'll start talking about that a little bit now. I should also mention there's going to be another workshop in this meeting that you can find online where we go into a little more depth in terms of how you go through this process, and we go through a few more difficult clinical situations and a few things like that. So keep an eye out for that as well. So what I'm going to do now is just show you some of the basics of ECG interpretation. And so if you have a 12-lead ECG in front of you, the first question is kind of like, what the heck is this? How do I read this? And the first thing I would do is start to think about the boxes. So the important thing is that one small box is 40 milliseconds. One large box is 200 milliseconds. And so then 5 large boxes is 1 second on the EKG strip. If you're trying to kind of look at heart rate and to kind of measure heart rate in a quick way, another way to look at this is by remembering this, that, one big box means it's 300 beats a minute, then 150, 100, 75, 60, and 50. And you can see that this all lines up, because if you have 5 boxes, that represents 1 second, which means that if you're getting 1 beat every second, then you're getting 60 beats a minute. This is just kind of a good way to kind of eyeball it. If I'm looking at the heart rate, usually I'll just look at the ECG printout, because that's pretty accurate. Another way to look at this and to measure heart rate in kind of a quick way is to remember that a 12-lead EKG is 10 seconds long. So if you look at the whole thing and you just count up the number of beats and then you multiply it by 6, because 10 times 6 is 60 seconds or 1 minute, then you get the number of beats a minute. So in this kind of situation, if you count all these out, you get 12 beats and you multiply by 6 and you see that it's 72 beats a minute on average, around there. So let's say you're kind of have your 12-lead EKG in front of you and you're trying to figure out what to do. The first thing to realize is that QTC can vary from lead to lead, and so there are some recommendations about which lead you should use. So usually you want to use the lead that's showing the longest QTC. That's usually lead 2, V2, or V3. I would kind of look at those 3. I would try to find the one that kind of most clearly shows the start of the Q wave and the end of the T wave, because if you really can't see that, it's going to be really hard to kind of manually calculate the QTC. One important thing to kind of notice or to note is the presence of U waves. So U waves are these little kind of tiny waves, these little blips on the EKG that happen right after the T wave, and they can obscure the end of the T wave, which is a problem. They typically represent repolarization of Purkinje fibers. They're not super important in terms of QTC measurement. The big thing is that you want to figure out how you can measure the end of the T wave. And so one way to do this is to look in leads that don't have U waves, if that's possible, or you can use the tangent method, where you kind of draw a line in a tangent to the steepest downward slope of the T wave and see where that intersects with the isoelectric baseline. And you use that as the end of the T wave. So if you wanted to see what this looks like, here's a nice ECG tracing, and you can see the P wave, the QRS complex, the T wave, and then my goodness, there it is. There's this like pesky U wave that is kind of obscuring the end of the T wave. And so the way that we would kind of look at this is that we would draw a line to mark the beginning of the Q wave. We would draw a tangent to the steepest downward slope of this T wave. We would then look at where the isoelectric baseline is. It's this part that kind of is at the very end. And then we would find that intersection point, and we would mark that as the end of the T wave. And then we would just count up the number of boxes. So if you recall, each small box is 40 milliseconds. So if you look here, there's 10 boxes plus a little bit, which is 410 milliseconds. Just another situation where we can kind of practice this. Here's another kind of ECG. In this situation, we're going to look at lead 3. And what we're going to try to do here, this is kind of a good one, because it's not, the isoelectric baseline isn't as clear. It's a little bit dirtier. It's a little more kind of, what you would see in clinical practice. But what we're going to try to do is we're going to try to find the start of the Q wave, which is right over here. We're then going to look for the end of the T wave, which I would put right over here. And then we're just going to count up the boxes. So again, 40 milliseconds per small box. You count them up, and what do you get? 10 boxes plus 3/4 of a box, which is 30 milliseconds, and you get 430 milliseconds. Once you kind of do this, you're obviously going to want to go back and put it into one of those correction formulas that Scott mentioned earlier to kind of calculate the corrected QT interval. The next thing I want to mention is just atrial fibrillation. So this situation can make it difficult to calculate the QT because there's variability in the RR intervals. And so there's two different methods that you can use to correct this. One is to just calculate the QTC of several different complexes and then average them out. The other is to kind of try to look at the longest and the shortest complex and then average those. The next thing I just want to mention, and the final thing I'll mention actually, is another situation where measuring the QTC can be difficult. And that's the setting of ventricular pacing or bundle branch blocks. If you recall from what Scott mentioned at the very beginning and what I mentioned a few minutes ago, when we think about the QTC, it's really measuring two different things. It's measuring the QRS complex, which is ventricular depolarization, and then the ST segment and T wave, or the JT interval, which is the ventricular repolarization. And let me just step back. I'm just remembering before I did call the ST segment the JT segment before, but it's really the ST segment. And so in terms of ventricular, so when we think about QT prolongation, the risk really comes from delayed repolarization. The problem with ventricular pacing or bundle branch blocks are that those things actually cause a widening of the QRS complex. And so when you have that happen, it makes the QT interval look longer than it really is, but it doesn't really reflect the kind of an increase in risk. And so what you want to do is kind of take a look here. So if you look at this particular tracing that's looking at someone who's ventricularly paced, you can see that this QRS complex is very wide, and you have a very kind of pretty normal JT interval with the ST segment and the T wave. And so while the QT interval will look long, it's not really that this patient has an increased risk of arrhythmias. It's really just that their QRS complex is prolonged. And so there's a couple ways to deal with this. Number one, you could correct for the wide QRS complex. So there's something called the fixed QRS method. And so what this basically does is it takes the kind of wide QTC, this whole long thing, you subtract out the prolonged QRS complex, and then you add back in an ideal QRS complex. So this is kind of like a way of normalizing that QRS complex so that you can get a more accurate QTC. And in this case, kind of an ideal QRS would be 95 milliseconds in men and 88 milliseconds in women. Another kind of way to do this would be to look at this particular method, which is taking kind of the Hodges formula that Scott mentioned before and doing something called the Bogosian correction. So in this case, what you're doing is you're taking the typical Hodges formula. So you're adding 1.75 times heart rate minus 60, just like you normally do. But instead of just including the QT interval, you're subtracting out half of the QRS interval. And so this is basically kind of taking this QRS complex, saying, let's pretend that we're only half of what it is, and let's see what it looks like here. So that's another reasonable approach. Or you could use a corrected JT interval, okay? So in this kind of situation, you would take the QTC, and then you would subtract out the QRS, and then you would get a corrected JT interval. And in this kind of situation, you would look at an upper limit of 355 for men and 372 for women as kind of the upper limit of normal. Anything above that would be a prolonged QT interval. When you're doing all of this, typically linear formulas like Hodges formula are the ones that are recommended. So with that, I'll kind of stop there. I will turn it over to Margot, who's going to talk a little bit more about things. I hope you kind of continue to learn more about QT prolongation. And if you are really interested in learning more about the specifics of how we measure QT and different types of challenging clinical scenarios, I would encourage you to come to the Advanced QTC workshop that's also available during the annual meeting. So thank you.
Welcome to part 3 of the QTC skills course. I'm Margot Funk. I have nothing to disclose. So in this next portion of the course, you will have the opportunity to practice your ECG measurement skills in real time. So we're going to begin with ECG number 1, and you'll see here that the computer read has been intentionally left out so that you can practice your measurement skills without external influence. Lead V3 here has been magnified to allow for closer inspection. For this ECG, there are 5 questions to answer. Number 1, what is the uncorrected QT interval? Number 2, what is the RR interval? Number 3, what is the heart rate? Number 4, what is the QTC using the Friedreich's formula? And number 5, what is the QTC using the Hodges formula? So I encourage you now to pause the video, go ahead and perform your measurements and your calculations, and then resume the video when you are ready. So our first task is to measure the uncorrected QT interval. And remember that the best leads to measure the QT with are V2, V3, or lead 2. You can also measure it in the lead where it's easiest to identify the end of the T wave. So as we've already seen in this ECG, V3 looks fairly straightforward, so we're going to zoom in there. So first we will identify the beginning of the QT interval, and then followed by the end of the T wave. And in cases where it's difficult to identify the end of the T wave, one can use what's called the tangent method, where you draw a tangent to the steepest downward slope of the T wave, and then you mark where it intersects with the isoelectric baseline. We can then count the number of boxes, remembering that one small box is 40 milliseconds and one large box is 200 milliseconds. So this QT interval is 11 boxes or 440 milliseconds. Next, we must determine the RR interval, which is used in the Bizet formula and also in the Friedreich's formula. So remember that the RR interval should always be the one that precedes the QT interval that you're measuring. So in this case, the RR interval is 17 boxes, which is equal to 680 milliseconds. So next question, what is the heart rate? The easiest method to determine the heart rate is by remembering that a standard 12-lead ECG is 10 seconds. And if you count the number of beats and multiply by 6, you get 14 beats times 6, or 84 beats per minute. Our fourth task is to calculate the QTC using the Friedreich's formula. So remember that Friedreich's is equal to the QT over the cubed root of the RR interval. And note that in both Friedreich's and Bizet, the unit that you're going to use for the RR interval is in seconds, whereas the QT interval will be in milliseconds. So plugging in our earlier measurements, we get here a QTC of 500 milliseconds. Notably, Friedreich's has been recommended as the best formula to use in cases of atrial fibrillation. So finally, correcting for Hodges, which uses the HR heart rate in beats per minute rather than the RR interval, we calculate a QTC here of 482 milliseconds. So congratulations, you've now completed the first ECG. And as you practice more and more, it's going to get easier and easier. For this ECG, we can see that the Friedreich's and the Hodges formulas yield fairly consistent results. And I find that it can be a fun experiment to calculate your QTC using multiple formulas just to get a sense of the variation, especially as your heart rates deviate from 60. So for ECG number 2, we've again zoomed in on V3, and we're going to determine the same intervals and corrections as we did in ECG number 1. So please go ahead, pause your video, perform your measurements and calculations, and then rejoin the video when you're ready to compare. So our first task is to measure the QT interval. And so we're going to start with the beginning of our QRS complex. Now on this ECG, it's a bit more difficult to determine where the T wave ends. You can see that there are 2 downward slopes. The first is fairly steep, and the second, which is at the end of the T wave, is quite slurred. By most standards in a case such as this, it's really most appropriate to use the tangent method of the steepest downward slope. You'll see, though, that when we do this, the T wave ends much earlier than the slurred out portion. And I think this is worthy of comment because when you see a slurred T wave, it indicates something called prolonged transmural dispersion of repolarization. Transmural dispersion of repolarization is a phenomenon whereby the 3 different types of myocardial ventricular cells repolarize at a different rate. And as you see those rates diverging, the opportunity really increases for an early after depolarization to trigger torsades. And so for this EKG, even though we're not including the slurred portion in the T wave measurement, we should increase our level of vigilance, especially if we see that multiple QT prolonging medications are on board. So when we complete the measurement for this QT, we see that it's 13 boxes, 520 milliseconds. So next we will measure the RR interval. And again, we use the preceding RR interval. In this case, we have 4 large boxes for a total of 800 milliseconds. Next, to determine the heart rate, we use the same method as before. We're going to count 12 beats in this 10-second period for a total of 72 beats per minute. And now to correct with Friedreichia, we're going to plug in our QT and our RR interval. Remember, RR is in seconds. And we're going to get a QTC here of 560 milliseconds. Finally, to calculate Hodges, we're going to plug in our numbers, and we get a QTC of 541 milliseconds. So it's interesting here that even though we didn't account for the slurring at the very end of that T wave, we do still have quite a prolonged QTC, and we would consider this to be a high-risk ECG. Now for the third and final practice ECG. So here you're asked to measure the uncorrected QT interval and then to calculate the QTC adjusted for ventricular pacing using the Boghossian method with Hodges and then using the JTC also with Hodges. And note that this patient is a man, which will matter when you do your JTC calculation. So in this ECG, it's fairly easy to identify the ventricular pacing, both by the pacing spikes and the wide QRS. These calculations are going to require you to perform a few other measurements. So when you pause the video, feel free to look back to the earlier sections of the course to help you. And then when you're ready to compare your answers, please restart your video here. So now resuming for ECG number 3, first we will measure the QT interval. And in this case, the end of the T wave is pretty easy to identify. We get 10 boxes for 400 milliseconds. Next, we will perform the measurements needed for the Boghossian QRS correction and the Hodges heart rate correction. So to measure the QRS, we'll start at the same position where we start our QT measurement. The end of the QRS complex is marked by the J point, and we count for QRS 4 boxes or 160 milliseconds. This confirms that our QRS is wide, remembering that the normal range is 80 to 100 milliseconds. To correct for the wide QRS from ventricular pacing, we will first use the Boghossian formula and the Hodges heart rate correction. So plugging our numbers into the formula, we get a QTC of 425 milliseconds. Using the JTC with the Z, we calculate the QTC minus QRS. But since Hodges is a linear formula, it's okay to calculate the JTC first. So plugging in our numbers, we get a QTC of 345 milliseconds. And recalling that this patient is a man, the upper limit of normal in men is 355 milliseconds. So using either calculation, we can consider this a low risk EKG. So now that we've reviewed medications, cardiac electrophysiology, and you've had a chance to practice your ECGs, in this final section, we're going to put this all together to discuss the approach to risk stratification and mitigation. It's really important to emphasize that when determining if and when a psychotropic medication should be prescribed, this must be based on a thoughtful assessment of risks versus benefits. What is the risk of torsades versus the benefit of using the psychotropic medication? Alternatively, what is the risk of torsades versus the risk of not giving the medication? And is there any way to mitigate the risk and to shift the balance? So let's think about this from the perspective of an agitated, delirious patient in the ICU. What do we know about risk of torsades versus benefits of a psychotropic? So from the torsades risk standpoint, you have increased risk due to the very nature of being in the ICU. You have increased likelihood of concurrent QT prolonging medications being prescribed. There's certainly a higher risk of having parenteral administration, which can increase the rate of drug delivery to the heart. Your patients are more susceptible to fluid shifts and electrolyte imbalance. They'll be more likely to have renal or hepatic dysfunction, and likely they'll be older. Considering the benefits of using the psychotropic, you may have better control of agitation. You can protect the patient from injury. You'll have protection of life-sustaining external lines or devices that otherwise the patient might try to remove. It may prevent reintubation and sedation of a patient, and it may also prevent the use of restraints. Another way to conceptualize this is by stratifying risk. In this inverted triangle at the bottom in green would be your low risk patient. So a patient with a QTC less than 500 milliseconds. In yellow, you might have a patient with a prolonged QTC greater than 500, and they are agitated in the ICU. In light orange, you might have someone with prolonged QTC greater than 500, they're agitated in the ICU, they're intubated, and let's say they require fluconazole and azithromycin, both medications that we know increase risk of torsades. Going one step higher into the dark orange, let's say you have someone who's prolonged past 500, they're agitated, they're intubated, they are requiring fluconazole, azithromycin, they're also on hemodialysis, and they have a history of torsades. So you see the risk is increasing. And then finally, you may have a patient who has so many risk factors. The QT is prolonged past 500, they're agitated, intubated, requiring fluconazole, azithromycin, and now add on dofetilide, methadone, and they're getting hemodialyzed, and they have a history of torsades. So you can think about your risk stratification from low risk to high. Why is this helpful? So let's say we really want to use IV haloperidol in this patient. Are there ways that we could collaborate with our clinical partners to potentially mitigate some of the risk? So for the patient in yellow, we could potentially add on continuous telemetry, and we can aggressively replete both potassium and magnesium. For the patient in orange, we could discuss non-QT prolonging antibiotics and antifungal options with our infectious disease team. For the patient in dark orange, we could discuss with the nephrology team optimization of electrolytes. And then for the patient in red, we can actually discuss temporary overdrive pacing with our cardiology team. This diagram is not meant to communicate a prescribed recommendation for these unique clinical situations, but rather it's meant to highlight the importance of working with your entire clinical team to assess overall risk stratification and mitigation strategies. Another important take-home is really the importance of this multidisciplinary collaboration when stratifying risk. The conversation really has to involve the ICU team, psychiatry, cardiology, and all of the other consultants who have a stake in this case. And the questions for the team should always include, what are my options and what are the alternatives that might mitigate my risk? Collectively, what are the tricks that we have up our sleeves that can help the situation? So when you're considering prescribing a QT prolonging psychotropic medication, when is it appropriate to consult cardiology? When the patient has no risk factors other than the medication itself, no consultation is needed. If your patient has known structural or functional heart disease and other risk factors, then you should consider consultation or at least a curbside with the patient's existing cardiologist. If you'll be giving multiple high-risk medications, or if your QTC is greater than 500, or if there's a sudden increase in the QTC by 60 milliseconds after you initiate a medication, then it's appropriate to refer to cardiology. And if your patient is having cardiac symptoms like dizziness, syncope, or palpitations while they're on a QT prolonging medication, then they should absolutely be seen by cardiology immediately, either in the office or in the emergency department. For extremely high-risk patients, a potential risk mitigation strategy is through cardiac overdrive pacing. So this is a rhythm strip showing the onset of torsades. Torsades typically arises from what's called an early after depolarization, and this happens in the setting of bradycardia or a prolonged QTC. This is also known as the R on T phenomenon, essentially, which means that the QRS complex of an ectopic beat falls right on top of the peak of the T wave and triggers torsades in that context. Since this typically happens in bradycardia, one mitigation strategy is to actually speed up the heart. Overdrive pacing at a rate greater than 70 can decrease the risk of early after depolarizations that can cause a reentrant rhythm. And so any patient with a cardiac implanted device, including pacemakers and ICDs, have the capability to overdrive pace. Typically, implanted pacemakers are set to backup pace at rates of 40 to 50 beats per minute. And that's so that we can preserve the battery life of the device and also to avoid ventricular strain. But the rate can be increased. And so for high-risk situations, this is important to consider. In extremely high-risk sick patients who don't have an implanted device, a patient can have temporary transcutaneous or transvenous pacing wires actually placed for this purpose. It's less common for patients to have chemical overdrive pacing with isoproterenol, but that also can be used. A final high-risk group to mention are patients receiving hemodialysis, in whom drastic shifts of fluids and electrolytes are very common. QTC prolongation is very common in hemodialysis patients, and sudden cardiac death is the leading cause of death in hemodialysis. There are actually a lot of contradicting studies regarding the impact of the dialysate electrolyte concentrations and the serum to dialysate gradient on the QTC. And in 2019, there was a study by Kim et al. Who demonstrated that there was no effect of changing the dialysate concentration on the QTC. So in other words, changing the dialysate concentration would not be a helpful risk mitigation strategy. Their study confirmed and highlighted that serum ion calcium and potassium levels are inversely associated with high-risk QTc prolongation, and really that close attention to serum and ionized calcium and potassium may mitigate risk for QTc prolongation and sudden cardiac death. Bottom line here, work closely with your nephrology team in high-risk patients on hemodialysis. So we've made it to the end. So in our final minutes, let's summarize some of the key take-home points from today. So first, Bezet is the most widely used correction formula, and it's programmed into most ECG machines, but it is not a consistently reliable method of correction, and it overestimates the QTc interval at high heart rates and it underestimates in bradycardia. Remember that manual measurement with heart rate correction using Friedreichia or a linear formula like Hodges or an alternative population-based nomogram they are all more consistently reliable techniques. Currently available sources that classify drugs according to level of risk are based of evidence of variable quality and validity. So though they are good resources, you can't take them at 100% value. Medications are only one of the several possible risk factors for QTc interval prolongation. Combinations of these risk factors can create cumulative risk for TDP. Co-administration of 2 or more QTc interval prolonging medications is of particular concern. And also know that guidelines and warnings really vary from country to country. In patients with significant cardiac risk factors, drugs with known risk to prolong the QTc interval or those with a regulatory warning should be avoided when relatively safer alternatives are available. Perhaps most important, there is no absolute QTc interval at which a psychotropic drug should not be used. The risk-benefit ratio in patients with pre-treatment QTc intervals greater than 500 must be assessed comprehensively with careful attention to risk mitigation strategies. And the treatment team must consider risk of failure to control high-risk pathology or of psychiatric decompensation. Routine cardiology consultation is not indicated when prescribing a QTc interval prolonging medication in a patient without cardiac risk factors. And when significant cardiac disease is present and or when other risk factors for QTc interval prolongation are present, cardiology input should be considered. So that will conclude our presentation. We really appreciate your feedback and we'll be happy to entertain any questions by email. Please don't hesitate to reach out to any of us. And we thank you so much.